Hi, Jonathan.
Hi, Emma. It's time for
Cut
Cut to the Case. And look, it's been a while, Emma.
Yeah, well, I saw an interesting case.
Well, that's good. So,
So imagine this, a 22-year-old that's fallen off a balcony, landed on their back.
Yep.
They're coming in, they can't move their legs properly. And their vital signs on the phone call were SATs of 100, blood pressure 85 on 60,
Yep.
and a heart rate of 110,
Okay.
GCS 13.
Right.
So what are you thinking about there?
I'm thinking shock.
Okay, yep.
This is a trauma that's shocked and they've fallen from a height. So when I think shock trauma, I'm thinking hemorrhage, because that's the thing that I'm most worried about and will need to address straight away. But I'm also thinking obstructive shock, and that would be tension pneumothorax, tamponade, although tamponade would be, less likely in a blunt mechanism. So they're the things I'm thinking.
Any other types of shock? Remember I said he couldn't move his legs.
I heard what you said, and I remember. So can't move his legs. So has he got a spinal cord injury? Has he got neurogenic shock?
Not spinal shock?
Not spinal shock. What's the difference?
Well, what is spinal shock? That's where the spine is all.
So it's a temporary thing. So
Yeah.
neurogenic shock is more what we're talking about when you
Descriptive
have
about
a dysfunction of your autonomic nervous system, and you'll get a sensory level. So and there'll be all kinds of things that'll happen as a result of that.
All right, well, I'm going to move you on.
Getting back to this
How do you
guy,
prepare for this man?
How do I prepare? Can I say I'm worried? And I will say I'm worried. So what I'll say, I'll actually get my team together and I'll say what I'm worried about. And I'll say, this person, I'm concerned about spinal or neurogenic shock, but I'm concerned about hemorrhagic shock and obstructive shock. So as I set my team members up, I'll give them the brief about my concerns.
Good.
I'll also get some equipment. So I'll get some blood. I'll get a pelvic binder because he's fallen, maybe some splints, and I'll send some notifications. So I'll be getting some help. I'll get the surgeons and I'll get anesthetics, because if he does have, say he's got a broken neck, say he might actually need intubation, and so I'll need that. So it'll be a team. So there'll be equipment, notifications, team, and then a brief.
Yeah.
And again, my brief will be targeted by what I'm worried about.
So I would say that's your safety net, and I would flip that to your notifications and whatever it is at your site, your equipment, and then your team, and you're briefing your team on roles.
I think I said it better.
And so what they might need to do.
Yeah.
Yeah.
You need to do that. You need to have a little checklist to go through that, because if you don't, you're going to miss something.
Okay.
So, and one thing
I'm going to move you along.
One thing I like to do is just say, have I missed anything? Is there something?
Now, why is that? I'm going to pick you up on that.
Because trauma's a complex beast, and often you're a bit stressed and you may just forget things that are really important or obvious. Like you might forget to put a binder on the bed, or make sure there's someone who can hold the neck.
And it's about working in a team.
It's about working in a team. So, and it's not all on me.
Well, next step.
Patient comes in.
It's a little bit like an OSCE, isn't it?
It sounds like OSCEs, yeah.
So on the he arrives in pre-hospital. He's had 500 mils of IV fluid.
Sure.
He's not moving his legs, and his arms are moving not right.
This sounds the arm's not moving right.
Yeah, and so he remains hypotensive and tachycardic.
Yeah.
So and he's got a lot of neck pain. So what are you worried about?
Well, I am worried about neurogenic shock, but still that's lower on my list. I still need to make sure he's not bleeding. Good. He hasn't got hemorrhagic shock. And I need to make sure he hasn't got one of those causes of obstruction.
Okay, I'm going to move you forward from there and then just ask you the question, what are the signs that if you're suspecting neurogenic shock, let's say you've done your primary and secondary survey, you've excluded hemorrhagic and obstructive shock, what signs may you elicit on examination that support neurogenic shock?
So I'll be looking for the cause. So sore neck.
Yeah.
When I log roll him, has he got, or him or her, have they got a step deformity I can feel in the spine? Are there general signs of neurogenic shock? So instead of being cold and clammy, this person might be warm and vasodilated. So general features, and then the actual neurology itself. So, and we'd be looking for a sensory level. This person's not moving their legs. They're not moving their arms well. Maybe that means the sensory level is
C6, C7, something like that.
The arm. So maybe they're a bit weak somewhere, a bit strong somewhere. So where's the level? The
sensory
motor
level and a sensory level.
Motor and sensory level.
Any other signs, Jonathan? Sounds like an exam answer.
Look, it does. I mean, we can look for priapism,
Yeah.
log roll, do a PR,
Anal
it could be
tone.
a flaccid anal tone.
Yeah.
Are
And
they
often-
in urinary retention would be another thing
Yeah.
that can happen as well.
Yeah, and if you're resuscitating them, often they're unresponsive. They're not so tachycardic often, but not always.
Yeah, so it
And
might
the
be.
resuscitation is unresponsive.
So I think what you're trying to say is it might be that I give them volume and they don't respond the way I would think,
Yeah.
and they're not still bleeding.
That's
So
right.
so they're failing to respond to volume. So what do you
Yeah.
do next?
Well, here's your curveball.
Okay.
So we do.
I knew that'd be a curveball. I mean, it's sounding, look, this sounds awful, but and we do this unfortunately often, but there's got to be a curveball because
Yeah.
it's cut to the case. So what
Okay.
is it, Emma?
Yeah. So the patient is able to speak. They're not moving their arms properly and they're not moving their legs at all. They remain hypotensive, heart rate of 110. But the kicker is they have free fluid in their right upper quadrant.
A lot? How much? And how much is important? And this is one of the things that often comes around. If there's a little bit of fluid that I see on ultrasound, that's actually 600, 500, 600.
Okay.
So it actually is significant.
Yeah. I'm not going to allow you to sit on the fence.
but
What
is
do
it
you do? What's your approach to hypotension in this patient?
So so I could do an echo that will help me determine volume status.
You could, yeah.
I would start filling the patient with volume. So I'd be giving them blood, but I've already given them some blood, and you've said they're non-responsive. So
No, okay. So you're managing hemorrhagic shock. Is that what I'm hearing?
that's what I'm doing.
Yeah.
Yeah.
And what's your consideration in there? So you've got competing priorities, right? I think what you're saying is you're worried about neurogenic shock, but you've got this clincher,
the clicker.
yeah,
And maybe that's what's happening on the spine.
yes,
but
you've got the free fluid in the abdomen. So you're chasing.
What I need to know is there ongoing hemorrhagic shock and bleeding in this person's abdomen?
Well, they've got free fluid.
Yeah.
So what are you going to do?
Fluid. So, but I need to quantify that. I need to find a bleeding spot. I need to go to CT.
Okay, good.
And that'll give me information about the neck.
And in the meantime, when their blood pressure is 80, your mainstay of treatment is?
It's still volume, but and I think what you're leading me down to is when am I going to start noradrenaline?
Yeah, so you've got
starting?
you've got two treatment regimes, haven't you? You've got your ability to treat neurogenic shock with a vasopressor support, and then you've got chasing down this hemorrhage and treating the patient with blood products in a 1:1:1 warmed transfusion ratio.
Yes.
And I think that's what you're saying. You're going to initially treat hemorrhagic shock, looking for a response, and really trying to prioritize what the major investigation being a CT to figure out if there's bleeding.
And I tell you, if I've gone through, a MEP pack or 4 units of blood, or not even that, and he's still unresponsive, in this case, I'm thinking noradrenaline.
Yeah. Okay.
Because I think he's going to need. There's two things going on here.
Yeah.
And I need to get this person safely to CT.
Yeah. Well, you did.
Great. I got to CT. What did I see, Emma? What happened?
So there was free fluid in the abdomen, but there's no active bleeding, and it really wasn't clear where the fluid had come from.
So no blush.
That's right.
Because that's the thing. I mean, we're looking for a blush. We're looking to tell our surgeons, hey, here's active
something
bleeding.
to operate on.
There's something to operate on, or angioembolize.
Yeah.
So you're saying there isn't?
No, and the volume was small. Now, there was a C7 injury with impingement on the cord, and he, over the next half hour, really remained unresponsive to what was a large volume of resuscitation. And so we then really moved into that next phase of treatment of being able to adequately treat someone with neurogenic shock. What do you think about there?
So firstly, we need to support circulation. So these is vasodilated, so we need to vasoconstrict. So that's going to be noradrenaline or adrenaline, probably noradrenaline. And then there are other supportive measures we should do for this person whilst we think about definitive management. So is he having an operation?
Yeah, that's right. So the definitive management being the neurosurgeons to look at decompression, I guess.
So what's the supportive? Well, you're getting at the supportive care, I think. I put the NORAD on.
Yeah. So
what else should I be doing?
In less complex scenarios, really for neurogenic shock, we're aiming for a high MAP. We're really aiming for a mean arterial pressure of about 80, really trying to enhance perfusion of that cord. But there are other things that we need to do, and we need to do this well. So we need to do pressure care, temperature care, bladder care, analgesia. I'm sure I'm leaving something out.
I'm interested in the MAP, higher MAP than normal. How come? So you're saying like your normal map you'd aim for is 70 something. Is this what we're doing?
Well, it depends on the scenario. In hemorrhagic shock, you're often aiming for a lower
Maybe go lower.
map, not map.
Why do I need a higher blood pressure? This guy hasn't got a brain injury.
No, but in many ways, it's like a brain injury. You're really trying to perfuse that central nervous system or the spinal
Because
cord.
there's not much else we can really do. So the best thing we can do is actually preserve those neurons.
And then some of the things that you're going to do for a head injury, you do for a spinal cord injury. So normal blood pressure, we said a bit higher, oxygen, and, you know, then the other supportive things like blood sugar. But things like neckties, head up 30 degrees, they're not really the case for this.
So that's raised intracranial pressure.
That's for raised intracranial pressure.
So there's a kind of a packet of things that go with a particular injury. So we've talked about the features of neurogenic shock and the things you look for. And then we've spoken about other injuries they may have, because this person would have other injuries, often pelvic fracture, often rib fractures, and treat that. But then there's the specific treatment, and then there's the supportive care.
Yeah.
And we've been through that.
Yeah.
So there's quite a bit.
So there's a case where we were thrown the curveball of wanting to manage the neurogenic shock, but, you know, really there was active bleeding, or we thought active bleeding, and so we needed, in the first instance, to do the right thing and manage hemorrhagic shock.
Yeah, I think that's tricky, and I think it needs frequent reevaluation. You need to be talking to your surgeons and going, well, look, I've seen some blood. Is it enough? Is this enough for you to go to the operating theatre right now? Or should we be going to CT to get more information? Or is it actually conservative management and let's try and manage the
and he hit the nail on the head. Actually, it was much more complex than what I've described, but the main...
You kept it simple. I appreciate that, Emma. Thank you. Yeah.
Good. All right. Thanks, Jonathan.
All right. See you next time.
See ya.
Bye.